Okay, everybody, if we could please start getting our seats, please. We're going to invite Dr. Lumsden to come up to the stage and get ready for his talk. His talk is going to be a little controversial, he tells me, which I think is kind of exciting. Okay, it's like herding cats. All right, so let's go ahead and get the doors closed. Dr. Alan Lumsden, Chairman of Cardiovascular Surgery and Medical Director at DeBakey Institute of Cardiovascular Education and Training, Houston Methodist DeBakey Heart and Vascular Center. And we're going to really enjoy this talk. You got your mic on. Dr. Alan Lumsden. Uh-oh. We had a mic.
Looks like we're good. All right. Okay, thank you, Joe. And again, appreciate the opportunity to be here. This one's not controversial. The next one's going to be controversial. So what I'm going to talk about is lessons learned. And I think the theme that you're going to hear, let's see if I can get this working. Maybe, which one is it? There we go. Is the theme of this, I'll go back, is what we call the other guy's toolkit. And fundamentally, I think that a lot of the problems that we face on a daily basis probably can be fixed by walking in the OR of the guy next door who works in another specialty. But we don't do that. We're so kind of ingrained basically in what we do. It was fascinating to listen to the talk on blood loss this morning, and yet, how do you measure blood loss? We measure it by your hemoglobin. We have very crude ways of estimating that, and yet those techniques basically are out there. There are some little startup companies that do colorimetric analysis, and we get a cc by cc blood loss. Sometimes you don't want it, but there are very accurate ways basically of doing this. I think one of the reasons Joe has asked me to come and talk was because we've been kind of looking into other people's toolbox. When I went down to Houston, in the vascular world, there's a very well-known example, and that is the Greenfield inferior vena cava filter. And I'm sure everybody in this room knows about inferior vena cava filters, may or may not know about Greenfield. That was the first filter. And Laser Greenfield was the chairman of surgery, vascular surgeon up at Michigan. And when he was in training, he went home one night and he was sitting bemoaning over dinner the fact that he'd just lost a young trauma patient. Patient had come in, multiple injuries, he'd been fixed. 3 days later, died from a blood clot that went to his lungs, a pulmonary embolism. And he happened to be having dinner with his next door neighbor, who was a guy called Garmin Kimmel. He was an engineer. He was run his own oil services company. And he said, so tell me what happened. He said, this thing came out of his legs, went up through this pipe into his lungs and killed him because you need to put a filter in that pipe. I said, well, you can't put a filter in a pipe. He said, sure you can. I said, you mean like a sieve? He said, no, that's stupid. You can't put a sieve in a pipeline. The whole damn thing blocks off. He said, you need to exploit laminar flow. There's a concept from us. And you need to do centerline filtration because that's where the big particles travel. They get caught in a filter. They're held there and blood flows around it and you don't block off the pipe. That led to the development of the Greenfield filter. The physician who identified the clinical need, the engineer who are really the smart guys who solved the problem, and then they happened to hook up with a guy called John Abley, who was a businessman. He started Boston Scientific. And so it was that triumvirate of these three people who developed the entire concept basically of filtration. And so going down to Houston, the three biggest businesses there are medicine, aerospace engineering at NASA, all human spaceflight goes through Houston, and the oil and gas guys. And that's where all the money is in town. And to quote one of my partners, Mahesh Ramchandani, said, when you're going to go fishing, you want to go where there's fish. So if you've got to raise money in town, you better go where the money is. And so it's not a bad idea to be in front of the oil and gas companies, and this is the hook. And so we started this, and this was the initial logo, and it shows a blood vessel which morphs into a pipeline. And we were looking for crossover technologies. When Dr. Skipper has a problem and he goes talk to another surgeon, 90% we're kind of trained the same way. He goes and talks to a cardiologist. Now we know we're different from the cardiologists, but even they have come through same medical school training, same cardiovascular hemodynamics. You need to be talking to people who do but fundamentally have no preconceived notions about the constraints. And that's where you need to be basically in the other guy's toolkit. And so that was the concept really that was developed. That's when it started. At that time, we kind of made this little list of, what are the crossover things? And 3D reconstruction, 3D projection, how do we simulate things? How do we make 3D models? All of these things basically were present in oil and gas, and subsequently we added NASA into it. And you can see basically what some of these opportunities were. I'm going to show you that. Now, as we added NASA, we didn't go to NASA. They came to us. They said, hey, we've been looking at what you've been doing, and we're very interested in moving our technologies out into the into the general public. NASA is under congressional mandate to give away their technologies. They are measured by the number of companies and ideas that they take and they move out. They publish a book called Spin-Offs, which is very interesting. The things that come out of the space program and basically are commercialized and moved out into it. So they're very end. They'll give you this for almost nothing. But they don't seek you out. They don't know how to do that. They expect you to come to them. Therein basically lies one of their problems. And what you're looking at here is Robonaut. And Robonaut is the most advanced humanoid robot, that's either on the planet or out of the planet. Why is it a human? It's humanoid because everything about NASA is launch weight. How heavy is the payload that they're going to put up into orbit? And so they don't want to set two sets of tools, one for an astronaut and one for a Robonaut. So this is a humanoid robot that can use exactly the same tools as an astronaut. And oh, by the way, look at the front of the panel, on the front of Robonaut. It says GM/NASA. This is a joint project between the automotive industry. They wanted a robot that could work side by side with a person on an assembly line and not kill that person at the same time. This robot has got like a 10-foot wingspan, is very powerful. If you stand beside it and it does that, it will stop instantaneously when it touches you. And so that was the challenge. This was two different groups that came together and tried to fund the development basically of Robonaut. And Robonaut's on the space station, and we'll show you how we've been kind of interacting with it. And this is our new logo. It is the pipeline in the shape of a heart with a rocket ship basically blasting up through it. And so we run this once a year. It's in the first week in December. And this is it being held, in Houston. And we're going to show you some of the examples of what we have learned from working with people who are in the oil and gas business and in NASA. Bottom right is Luca Palmitano. Luca Palmitano you probably all heard about, but just don't realize what he was. Luca was the Italian astronaut who was outside the space station. They go out as buddies, kind of like diving, and kind of the way we trained when the Ebola epidemic was taking place. A lot of the training concepts, can also be taken from places like NASA. And Luca was outside the space station. All of this is recorded in Houston, managed from Houston. He said, there's something inside my spacesuit. Well, that's a little creepy, to be completely honest with you. Well, you can't touch it, and you can't see it. And his buddy was at the other end of the space station, and they got all these code words and said, okay, Luca, we've seen this once before. Just take your time. Terminate the mission. Terminate means take your time and head back to the hatch. Abort means get your ass in here as fast as you can. And they told the other astronaut to get towards Luca. And as he was moving towards the hatch, he said, this is getting worse very rapidly. It's in my ears. That's where the communication system is. I can't hear you. It's coming in my eyes. I can't see. And now I'm beginning to have trouble breathing. Every time I breathe, whatever it is going into my mouth. And at this time, the other astronaut arrived and said, yeah, there's a bunch of fluid inside Luca's spacesuit. He can't breathe. And so they said, start eating it. And so he would take bites out of this fluid and try to swallow it. Meanwhile, all his telemetry is being monitored in Houston. His heart rate is going off the charts. His respiration rate is going off the charts. Obviously, he survived, since now he's at Methodist telling his story. This is the most watched webcast in the history of pumps and pipes. And when he took his helmet off, it all spewed out. What happened? What happened was a function of his pumps and pipes. Inside these spacesuits, there's a heart and a pump and a circulatory system. And that filter that was in that system got clogged up with algae. He got infected. Infection is present in all the devices that we implant. It is also the most common reason that you hear of a pipeline blowing out. Microbial-induced pipeline corrosion is a billion-dollar-a-year problem in the oil and gas business, and we didn't even know it existed. So they're very interested in what they can learn from us and control infection that occurs in pipelines. What happened to Luca was an infection problem because he bust one of the arteries and it vented into a spacesuit. And we were imaging it. We took a spacesuit, we did this live, we imaged this so we could actually show, using advanced medical imaging, where the problem was. And they're now working on how do they prevent this. They prefer to not be dealing with these things. And so this is a lab that we have. This is a joint venture with Siemens. Siemens, I'm going to say to you, the most important booth outside. They're all important, aren't they, Joe? But for me, the future of cardiovascular disease is about imaging and integrating imaging into the operating room. And that's what this is all about. This is a lab that's designed to do 3D imaging. And I will say, I don't really give a damn how a CT is made, how an MR is made, how an IVUS or an echo is made. I care about how I take that, I integrate it into the operating room, and I use it to direct in a more minimally invasive way the procedures which I'm doing. And this is all about 3D imaging and integrating 3D catheter robotics. We've moved now from the intuitive surgical type robots to robots that will move around inside the blood vessels. And this, in that lab, actually, the first autonomous movement of an endovascular robot was actually performed. And this is associated with an MR. MR is one of the, we think, is the cardiovascular imaging modality of the future. There's some real technical challenges in integrating it, but this is an interventional suite that you can do with CT scan, MR. If you're going to fix a valve on a beating heart, you'd like to be able to image that real time. The challenge with echo is you've got to be a magician to understand it. Well, who on earth would put black and white images that you've got to have a magician to interpret it and tell you what you're supposed to be doing? The future of imaging is real-time, dynamic, and anatomical. Then you need an anatomist to interpret it. Dr. Skipper here is an anatomist. We are the anatomists, basically, of the 20th century. And so what's going to happen is the radiology department, the cardiology, they're going to outsmart themselves because you're going to have realistic imaging that looks like anatomy, and at that point in time, we don't need anybody else to interpret really what's going on. Anyway, that's a little aside. We're starting to do procedures. There's a whole NIH program with MR-guided cardiovascular interventions, and at that point, there will be no radiation really associated with it, but there's some challenges in really how to do this. Now, I'm going to show you this. So this is what I mean by advanced imaging, and this is a MR. No radiation, no iodine-based dye. They do get gadolinium, or they get ferriheme in patients, and so ferriheme can be used in patients with elevated creatinine. What you see here is a spectacular image of a dissection. Typically, you see a split down the middle of an aorta. Here's what you're seeing is this is dynamic. This is moving through the entire cardiac cycle. And it's this kind of imaging that allows you to watch maturation of that septum occurring and how surgeons have always known that if you wait 2 weeks, the tissue thickens up. Well, that tissue thickening up is a function, basically, of these biological processes, and we can now image that. Classification of acute dissection, less than 2 weeks, acute, more than 2 weeks, subacute or chronic. So something magically happens at the stroke of midnight on the 14th day where you change classifications. That is created by people who are trying to put categories so they can actually make reports. It makes no sense whatsoever because it doesn't reflect active biological processes which are taking place. And here's the candy cane image. You see all these little white and black things that are going through? That is showing you flow that is coming through avulsed intercostals. And that is basically showing that we're now down to a resolution of about 2 millimeters that you're actually getting there. This is all quantitative, so that we can actually measure what the flow is and what the relative contribution basically of these holes are. Okay, so how does this help? So the medical imaging is way ahead of what exists at NASA or in the oil and gas business. And so we would do behind-the-scenes tours. We'd take the engineers, and we'd show them a setup that we had. And they went, oh, my gosh, we need this. So we imaged the spacesuit. But the oil and gas guys really said, this is what we need to optimize well bores. So this is us on the front of ExxonMobil Shareholders Magazine. This is the most widely distributed magazine in the world. It's about 2 million distribution, talking about using medical imaging to optimize basically well bore. Now, how did this happen? First of all, they looked at an LVAD that we had that pumped fluid through a circuit so we could mount valves and look at them using 3D imaging. We're very proud of it, actually. The problem is we couldn't really stick it in the magnet because of that big giant LVAD that was there. And so they looked at this and said, oh my gosh, this is pretty crude. We'd only been working on this for about 3 or 4 years. And so we said, we'll build you something that's better than that. So they built what we call the heartbeat simulator. When that went up through Exxon, they thought their engineers were building an artificial heart. That caused all sorts of problems. And no, this is purely for testing. They built the software package that allows you to control the stroke volume curve. So if I knew Joe's left ventricular stroke volume and the pressures, we can program that into this. And that pump will deliver exactly that. Here's what it looks like when you put an MR. They have this drive line, so it's got to be outside basically the 3 Gauss line of the MRI, and it allows us to create patient-specific physiology and add that on top of patient-specific 3D printing. Now again, 3D printing is something that goes on in the oil and gas business. They tend to have 3D printers that are half the size of this room, which you can't get close to, but they make functional machines. NASA is very interested in this because they they don't have to send all the spare parts up there. So 3D printing is, these industries are very focused on that. 3D bioprinting, printing blood vessels, is the next frontier. And we hooked into one of the labs in Mayo Clinic. And so what you're looking at here is the left ventricular outflow tract. You can now print in different densities, so we can emulate the calcium that's in there. We can put it in the circuit. We can look at and compare, basically on the left, the patient echo and Doppler signals versus what we can create, and they're almost identical. And now this allows us to put it in MR and show all these path lines, calculate very accurately basically what the fluid dynamics are, and you can see what the Dyna-CT image looks like. And so these are just, and now we've taken this, we do this with blood vessels. This is one of our partners, John Bismuth, explanted pig model, taken basically, everting it, creating, you know, a system that we can actually put the pig aorta in it. Then we can create dissections, and we can watch this thing basically real-time propagate and strip out basically the images. And so this is a very valuable tool for us, and one that really doesn't exist anywhere else that I'm aware of. This is kind of what a pig aorta in that system looks like with a dissection, looking basically at these flow patterns really over time. It's kind of what it looks like. So this is, a lot of this has come by taking people basically from different industries that allow us really to use many of their analytical tools, computational fluid dynamics, finite element analysis. What does a drilling engineer and what does a endovascular surgeon, this is the so-called phase contrast image, this is where you get all the data out of it. And if you look at the what it says, entry 12, there's black and white image. White is flow in one direction, black is flow in the other direction. So you can be very accurate in characterizing the flow patterns that are going on inside the aorta in this dissection model. So again, come back to what does a drilling engineer and what does a, I'm going to stop that for 1 minute, and what does a endovascular surgeon have in common? We use imaging. We navigate hollow tubes to a target, we access that target, and then we deliver volume flow from a point A to a point B. In the oil and gas business, they told me they're in the flow assurance business. That's what they call it. I said, no, you're not. I'm in the flow assurance business. You're kind of passe. They said, but no, that's what we do. That's what we call it, is flow assurance. And they can hit a target 10,000 feet down, 5 miles offshore, using GPS, and never turn on an X-ray machine. How is that even possible? And can we learn how we navigate directional drilling? The huge change that occurred in the oil and gas business is directional drilling. It used to be that if there was oil and gas down below here, you had to buy this land, drill straight down in it. Now they can basically bend these things with baffles that come out, it looks like an atherectomy catheter. In fact, it's very, very like an atherectomy catheter. And that's how they essentially do this. And they're extraordinarily accurate basically in their planning. And so once they essentially establish these wells, it's not just a hole in the ground, they have to line it with metal from top to bottom with a whole bunch of branches. Looks like a very complex stent graft. And again, they can't see any of these things basically as they are moving forward. So lots of things that we can actually learn from them. And a rocket trajectory is calculated like an upside down drill. They're hitting these basically launch windows just like you got to hit this trajectory with the drill. So this is one of the great pictures actually from Pumps and Pipes. This is the neutral buoyancy tank down at NASA. They'd already discovered the value in working with people. They've taken many of the NASA training paradigms, they've moved it basically into deep sea divers, and they train in exactly the same pool using exactly the same training paradigms basically down in NASA. Now I was recently up at Emory, actually, that was my old boss, and I kind of just want to show you how what are their opportunities. The guy in the bottom left is Dr. Tom Fogarty. He's a heart surgeon. He developed the Fogarty catheter. There's nothing that's ever been developed that moves thrombus clot just like Fogarty did. He developed that when he was a medical student. He developed it basically because he was working with a surgeon who was trying to pull clot out, couldn't do it. He took the tip off a glove, and he took a long tube. He put a rubber band around the tip of the glove on the tube, put a syringe on the end, and showed that you could blow this thing up. That Fogarty catheter is probably the most widely used device for removing thrombus that currently exists today. So I think that, and he was a student. So have faith basically in your observations and things that you can actually do. And this is another example of the other guy's toolkit. I own the patents for subcutaneous endoscopic vein harvest. This was developed at Emory when I was watching one of our plastic surgeons, and this plastic surgeon's name, using that device. That's the guy, his name is Monty Eves, doing latissimus dorsi harvest. And he did it through a small incision, basically taking it out of his back, and a patient's back. And I went and said, Monty, that's pretty impressive. You ever think about taking the saphenous vein out? He says, yeah, but I never get a chance. So he was an assistant professor at Emory, as was I. Next day, happened to be at the VA. He's doing one of these cases. So I watched them. I said, hey, I got a fempop to do. We only need a piece of vein this long. How about you bring that system over? So he brought it over, and off we went. We worked with Ethicon, again, somebody else's toolkit, and that developed basically the endoscopic vein harvest system that was distributed by Ethicon. It's not very good, to be completely honest with you, and the guiding guys basically made it, a lot better. But, put my kids through college off royalties coming off endoscopic vein harvest. Another guy that comes along basically was Juan Parodi, and this is a guy taking two different pieces of a device basically and putting them together, and he transformed the development basically of endografts. And again, this was not something that I learned anything about. And so when you're faced, this is one of the better titles that I've ever seen, and then I'm going to stop here, is that this is actually from a guy who was the president of the Society of Interventional Radiology. And it's often looked at from the point of view of specialties. And the title of his presidential address was Revolution, Evolution, or Extinction. And it kind of appeals to me because on the top left is Mel Gibson in Braveheart. Didn't know about Braveheart. And so he was a good Scottish guy who led the revolution, but he came to a pretty sad end. In the middle is Charles Darwin, he was really about evolution. He was also in the Edinburgh University Medical School for a period of time, the Scottish influence. And then third basically was extinction. You can be huge. This is a picture of the Roman Empire. They came out of Italy, they swept through Central Europe, through Eastern Europe, Western Europe. They came up to the English Channel, that little island over there. They built boats, they moved over into southern England, and they swept right up through southern England. But you'll notice the bit at the top is still green, okay? Because that's where they came up against the Scots. And they built two walls. There's the Roman Empire from one side of the country to the other to keep the damn Scots out of the Roman Empire because they never conquered those guys. And so there's a variety of different ways in which we have to change, and we really have to be able to manage change. There are opportunities that abound. For example, if you're in LA, the opportunity to work with the film industry and animation, I think it's huge. We should be looking into the other person's toolkit, and sometimes that's in an operating room not that far from you. But we are so ingrained, basically entrenched in doing things the way we've always been able to do it. And I think it's time to open your eyes and look for solutions where they exist. I'm going over time, so I'm going to stop at that and say thank you again. Thanks, Joe, for the opportunity to come and present that.